for joining, the speakers, the participants, everybody. My name is Sven Jaffrey, and I am the CEO of the World Patients Alliance. And welcome to our webinar on medical errors in Europe, breaking barriers and strengthening reporting systems. So as you know, medical errors remain a significant challenge in healthcare systems all over the world, including across the European continent, affecting patient safety and trust. So despite advancements in medical practices, barriers to effective error reporting persist, limiting opportunities for learning and improvement. So in order to address these critical issues, the World Patient Alliance, in collaboration with the European Patient Safety Foundation, we are hosting this webinar. So today, we will discuss the current landscape of medical errors in the European continent, exploring solutions for improving reporting mechanisms and foster a culture of transparency and learning within healthcare system. We have a very distinguished line of speakers and panelists for the webinar with huge experience around medical errors in Europe. Next slide. So before beginning the webinar, there are some housekeeping announcements. Today's webinar is available in 50 languages through AI simultaneous translation, which means that you can hear the webinar in your own language. So to do so, there is a link given in the chat for Wordly. So what all you need to do is to go. So this slide will open up, and you will open up the language in which you want to listen to the webinar. So in Spanish, in Arabic, in Hindi, in any language you want to hear, just select the language and just put your name here. So two things only, your language and your name, and then just click attend, and then a new window will open. And you just only need to do, what you need to do is to just click on this speaker, and then you'll start listening in your own language. So on the first one, just select language, your name, and click attend. And the next one, just click on this speaker, and then you will listen in your own language. Next, please. And one more thing, if you have any questions, please, put them in Q&A. There's a box at the bottom of your screen, Q&A. You can put your questions here, and you can also, send comments through chat, but the questions need to come under Q&A. Now I hand over the mic to Helen Haskell, who is the chair of WPA's Patient Safety and Quality Council. She is also the president of Mothers Against Medical Errors and Consumers Advancing Patient Safety. She is one of the leading patient advocates working in the area of patient safety. She has remained the chair of the WHO's Patient Safety Advisory Group. So over to you, Helen.
Thank you, Hussein, for that nice introduction. Next slide, please. Now, I'm afraid I'm not going to give such nice bios for the rest of our speakers in the interest of time. We have brief bios online, and you can go to the webpage for this webinar at worldpatientsalliance.org and read their bios, as well as see the slides and the recording of the webinar after we are done here. So I'll just run through the webinar, through the agenda very quickly. We're going to start with Kate de Bienassis and David Kelly from OECD, health policy analyst there, who will give us an overview of reporting and medical errors and patient safety culture in Europe. Then Sven Staender, professor of patient safety and past president of the EU Patient Safety Foundation, will talk about methodology and potential in medical error reporting. And then they will be joined by 3 other discussants for a panel discussion. And we'll have closing remarks by Mirka Chikilova, the General Secretary of the EU Patient Safety Foundation. Please, at any point, if questions occur to you during the presentations, put them in the chat while you're thinking of them, and they will be passed along to me and to our discussants during the discussion period. We often run into the problem of not having enough time for discussion, so our speakers have kindly agreed to stay on for a few extra minutes, however long you would like, up to within reason, to continue the discussion. And then, as I said, everything will be available, including materials that they reference in their presentations on the web page for this webinar. Next slide, please. So these are our panelists and discussants. Synnøve Serigstad from Austria, patient advocate and public health expert. Anupoma, Synnøve Serigstad from Norwegian, the Norwegian Patient Safety, what is it? Healthcare Investigation Board. My apologies, Synnøve. Anupoma from Haque from Austria is patient advocate and public health expert. Jolanta Bilińska from World Patients Alliance will be joining us for the discussion, and you have already seen the bios for the first three. Next slide, please. Kate Bienassis, next slide, please. And David Kelly, health policy analyst from OECD, will start our first presentation. So over to you, Kate and David. Next slide, please.
Great. Thank you very much for the introduction, Helen and Hussein, and thank you very much to the World Patients Alliance and the European Patient Safety Foundation for having us to speak today. It's a very important topic, and I'm looking forward to discussing some of the OECD's work in this area and illustrate some of the scope of medical errors and the current state of patient safety culture in Europe, and also to unveil some of our new work on diagnostic safety. Just as a brief introduction, I primarily work coordinating the OECD's work on healthcare quality and outcomes. And just for some background about the OECD, we are an intergovernmental organization with 38 member countries. And our main role is to serve as a forum for countries to meet, exchange their views and experiences and policy implementation, and to benchmark. So that is to compare how these policies are working and how countries' health systems are performing against each other. And as an economic organization, we often take an economic view to many of our analyses. So you'll probably see that throughout our presentation, that we are looking at the impact of patient safety, both in terms of the human cost, but also the economic costs and the opportunities for improving the efficiency and value that health systems deliver. Next slide, please. So I will begin by describing the importance of the patient safety topic, which is substantial. And unfortunately, it's a very common occurrence. On average, around 1 in 10 hospitalized people experience a safety failure during their hospitalization. And this, as I said before, comes at a cost to health systems. And our estimates show that approximately 15% of hospital expenditure in OECD countries can be attributed to responding to safety failures that have occurred. We see that about 50% of patient harm originates in primary and ambulatory care. So while the emphasis is often on the hospital setting, attention also needs to be paid to other settings. And that safety lapses that result in hospitalizations account for more than 7 million admissions in OECD countries every year. What's more, much of this harm is preventable, particularly in long-term care. We see that over half of harm in this setting is potentially preventable, and that the annual cost of avoidable admissions to hospitals from long-term care facilities is equivalent to almost 5% of all spending on hospital care. Next slide, please. So as I said previously, the OECD is one of our main roles is benchmarking. So I just wanted to take this opportunity to share with you some of the data that we have available on patient safety and the occurrence of medical errors. So the first is administratively generated patient safety failures, which are those that are included in the table on this slide. We currently have a portfolio of a number of patient safety indicators related to surgical outcomes and obstetric outcomes. a number of indicators that relate to safe prescribing practices, and then indicators related to safety and long-term care. In addition to these patient safety indicators that are developed from hospital sources of information, we are also looking at other potential sources of information and expanding our portfolio of indicators that are reported from patients' perspectives and also from healthcare workers' perspectives. So I'll be elaborating on this a little bit more in the next slides. Next slide, please. Here's an illustrative example of one of the indicators I mentioned earlier, that is postoperative pulmonary embolism or deep vein thrombosis following elective hip and knee surgery. And here we see that the rates vary significantly across countries, with the potentially very low rates in countries such as Italy and Poland, and higher rates in the United Kingdom and Australia. This is an important indicator to look at because these poor outcomes can be mitigated through better prescribing practices and other surgical protocols to reduce potential occurrence of these events. However, we also see that these rates vary quite significantly, and part of this might be attributable to differences in coding and the frequency of coding. So that is why we will be discussing quite a bit later on in this presentation, the importance of error reporting and the culture within the healthcare system. Next slide, please. Another illustrative example of the current burden of medical error in Europe relates to prescribing practices. And here we're presenting one of our indicators that relates to the prescription of anticoagulation drugs for long-term prescriptions in combination with the non-steroidal anti-inflammatory drugs, which is something that is not recommended because it can increase the risk of bleeding or stroke. Here we see that among 100 patients that receive anticoagulating drugs, there is a significant proportion of patients that are also receiving prescriptions for oral NSAIDs. However, we do see that there's been progress in most countries, and most countries see a downward trend over time. So this is getting better. Next slide, please. Patients themselves are a really great source of information related to the occurrence of patient safety events. And we have a new resource that has been developed at the OECD called the Patient Reported Indicator Survey, which looks at patients who are 45 years and older that are receiving, are currently receiving primary care. And one of the indicators that we collect through the survey relates to those that have experienced an adverse event in the healthcare system. And we find that around 30% of Paris respondents did report having experienced harm or another patient safety event over the course of their care, and particularly in primary care. One of the advantages of this survey is that we were able to link it to other aspects of patient outcomes and experiences. So for example, in this figure, we see that levels of trust in the healthcare system among people where something went wrong over the course of their care and where nothing went wrong. And in general, we see significantly lower levels of trust in the health system among those who have experienced an adverse event. And that's really, I think, a meaningful finding because it shows the impact of individual experience and interactions on health system trust as a whole, which is something that policymakers are prioritizing in the current policy environment, is something that is incredibly important for communication and strengthening health systems. Next slide, please. In addition to patients, healthcare workers are another important source of information regarding patient safety. And one of the mechanisms that we have been using to look into how to interpret some of the more administratively collected patient safety indicators is to look at how the current practices of healthcare workers and how they feel about the safety of their work environment. And in particular, looking at the domain of the tool that we use that relates to reporting of patient safety events. So that is looking at how frequently events are reported, even those that might be caught or corrected before reaching the patient, and mistakes that could have harmed the patient but didn't necessarily reach the patient. So the reporting of patient safety events is really key, and the culture for doing this, because it affects how we can interpret and how much we can trust the administrative data that we're looking at. Our current work on documenting patient safety culture uses the Hospital Survey on Patient Safety Culture, which is a tool that was developed in the US by the Agency for Healthcare Research and Quality. And it has a number of important domains where we are able to look at the percentage of healthcare workers that have a positive perception in a certain theme related to patient safety culture. Some of the themes where we see consistently low scores across countries relate to staffing and work pace, also response to error, which is extremely important. That is, if they think that they will be treated fairly if mistakes are made, and that there's a focus on learning from mistakes and supporting staff involved with errors. In some areas, we also see that there's generally high performance, notably some of the more interpersonal related domains, such as teamwork, and that is if staff are working together effectively and helping each other during busy times. Next slide, please. Thank you. I just wanted to use this opportunity to dive a little bit more into the indicator on healthcare workers' perceptions of reporting safety events, given the theme of today's seminar on reporting systems. And this focuses specifically on our countries in Europe. And here we see that there's a significant portion of healthcare workers who don't necessarily have a positive perception about how they would report patient safety events if they occur. So there is quite a lot of room for improvement. Next slide, please. This is quite a busy slide, but I wanted to also highlight it. This looks at specifically at the previously mentioned domain of staffing and work pace. And what we see here is that there are significant differences between how safe staffing and work pace levels are determined based on the staffing category of the respondent. So here we see that there are differences between physician responses, nursing responses, and other clinical staff, particularly in relation to management, who often have a much higher perception of the safety of the workplace than those who are working on the front lines. Next slide, please. And finally, I wanted to highlight some findings from a recent report on patient engagement and patient safety, which is a part of our Economics of Patient Safety series, and particularly the involvement of patients in reporting systems, which is a really key way to ensure that reporting systems are more effective, are capturing the events that are most meaningful to patients, and to also ensure that patients' voices are being used to feed into reporting systems. So I've highlighted the policy domain here related to public reporting of patient safety events and indicators. And you can see here that in general, there has been low patient or citizen involvement in the development of these patient safety initiatives to date. By countries, and that a number of countries have also not necessarily implemented these policy interventions, which is an area that could be further developed. Next slide, please. However, one area where we have seen that countries have made quite a bit of progress relates to establishing integrated patient complaints reporting systems. So here we see that while a number of countries still have not implemented these systems, most countries have, and that the level of patient involvement in developing these systems is generally much more, is much stronger. And in a number of cases, there are examples where patients or citizens have been involved as partners or co-designers and have had a key decision-making role in the development of the cycle of the patient safety initiative. Next slide, please. So now I will hand over to David Kelly to deliver the second part of the presentation, focusing specifically on diagnostic error. Thank you.
Thanks very much, Kate. I hope you can all hear me. I'm very pleased to give the presentation. So the second half will focus on diagnostic safety as a major component of patient safety. And as Kate has just mentioned, the next publication in this series will focus on the economic costs of diagnostic error and lapses in diagnostic safety, in addition to the harm and burden from this common issue. Misdiagnosis is estimated to affect most people in their lifetime. And we do estimate that approximately 10 to 15% of all diagnoses made represent a diagnostic error. And this may be a wrong diagnosis, a delayed diagnosis, or an entirely missed diagnosis. In addition to misdiagnosis, overdiagnosis is another common condition that is not without consequence for patients and providers. Where overdiagnosis results in overtreatment, it can lead to patient anxiety and additional healthcare costs, and treatment that is administered without providing any real clinical benefit to patients, while at the same time exposing them to potential harms. And the healthcare expenditure that is allocated towards overtreatment is represented to account for almost 3% of total healthcare expenditure, so considerable wasteful expenditure that could be used elsewhere. Diagnostic error is the single largest source of serious harms resulting from patient safety failures. To give some context, misdiagnoses of major diseases are estimated to account for almost 2.6 million diagnostic errors in the United States every year, and that is projected to account for up to 371,000 deaths every year, leaving 424,000 people permanently disabled as a result of diagnostic error in the United States. Next slide, please. So what are the common conditions that represent the greatest burden for diagnostic error? As part of our upcoming report, The Economics of Diagnostic Safety, we examined the burden of diagnostic error across 3 common conditions that are routinely encountered in both primary care, hospital care, and ambulatory care. So among cancer, the problem of misdiagnosis can frequently occur, whereby the diagnosis is delayed or confused with other conditions. For instance, in lung cancer, it's estimated that between 23 to 38% of lung cancer cases were initially misdiagnosed. And the issue of overdiagnosis, where patients are diagnosed with a condition which may not, had it gone undiagnosed, have resulted in clinical disease for them during their lifetime. For breast cancer, it's less of a problem, and it's estimated to represent around 10 to 15% of cases. But the problem is much greater for prostate cancer, and at approximately 40 to 60% of cases of prostate cancer may represent potential overdiagnosis. And it is particularly an issue for thyroid cancer, where worldwide estimates are as high as 76% of thyroid cancers representing overdiagnosis. Moving on to neurodevelopmental and mental health disorder. For overdiagnosis, we have observed a 50% increase in the rates of childhood ADHD, or attention deficit hyperactive disorder, diagnosis among children. So not all of those will be attributed to overdiagnosis, in that there may be better recognition of the condition, but it is estimated that a significant portion do represent overdiagnosis. Conversely, then, the condition is estimated to be underdiagnosed in adults, and a recent survey from the UK estimated that perhaps only 1 in 9 adults have been accurately and timely diagnosed with ADHD compared to children. For bipolar disorder, misdiagnosis and delayed diagnosis is a particular issue, in that the median time to diagnosis is over 300 days in psychiatric presenting patients with this disorder before they are correctly diagnosed with bipolar disorder. The final condition we look at in our report is of sepsis, which is difficult to diagnose clinically, in that there is no specific diagnostic test which will diagnose you specifically with sepsis. So it often relies on a clinical diagnosis, often outside the hospital setting. And it's estimated that up to 10% of cases involve a diagnostic error, so either a misdiagnosis or a delayed diagnosis of sepsis. and that in up to a third of cases of sepsis, they actually represent people having been misdiagnosed with it, in that instead of having, for example, a bacterial infection and being treated with antimicrobials, they in fact had perhaps a viral infection that didn't require antimicrobial therapy, and that misdiagnosis and administration of inappropriate treatment has consequences for both patients and healthcare systems, and they can range from the additional cost to the healthcare system and the patient to unnecessary hospitalizations or complications that warrant hospitalization and potential mortality. Next slide, please. Our recent survey administered by the OECD to our member state countries was on the reporting and the collection of data related to diagnostic performance and diagnostic error. And we focused the survey on common conditions where there is considerable potential for diagnostic error. So for sepsis, we collected information on the following indicators as a means of assessing whether countries routinely collect and report data related to diagnostic error for sepsis. And you can see we received replies from approximately 18 member countries, so half of the OECD members, and about half of them reported that they had either a treatment protocol or a specific pathway for patients diagnosed with sepsis to encourage early diagnosis and treatment. Some countries reported a specific icon for patients that are diagnosed with sepsis in the emergency department. Relatively few countries reported indicators around time for treatment after diagnosis of sepsis to monitor what are those time delays. And implementation of sepsis bundles for sepsis care was reported by approximately half of the countries that replied to the survey. It is important also to code sepsis diagnosis correctly in medical coding systems so that it can be correctly identified and then reported at a national or regional level. And for policies to improve the harmonization and the consistency of coding, those were reported by half of the countries that were surveyed. So as you can see, there is work to be done on the uniform recognition, data collection and reporting of indicators to measure diagnostic error related to sepsis. Next slide, please. For cancer then, we specifically looked at cancer screening as part of the diagnostic process for cancer. We recognize that screening is not in itself a diagnostic test, but it is part of the diagnostic process, particularly for common cancers for which there exist screening programs, such as breast cancer, colorectal cancer, and cervical cancer. And as part of our definition of diagnostic error, we include not only diagnosis being timely and accurate, but also it being communicated between healthcare professionals and essentially to the patient. So of the 18 countries who replied to the survey, the majority did report indicators measuring false positive rates from screening and the positivity rate, so the recall rate for further diagnostic investigations based on those who had a positive screening result. Whereas a lower number of countries reported indicators around the false negative rate from screening, because false negatives are an expected, albeit a rare consequence of cancer screening, in that they're not diagnostic tests, but they are screening tests. So reporting of these diagnostic performance indicators is important to allow countries to evaluate the effectiveness and the performance of their screening programs. Next slide, please. So how can we address diagnostic error across the healthcare system, and what are the potential levers that exist to improve patient safety from a diagnostic perspective? So beginning at the diagnostics level, so how diagnostic tests and investigations are used and interpreted, there can be policy implemented to improve the clinical acumen or the clinical practice of people ordering diagnostic tests and interpreting them, and also in settings where diagnostics are not available to improve clinical performance around diagnosing common conditions in a timely and accurate manner. Additionally, there is opportunity for policy improvements for encouraging rationalization of diagnostic tests to avoid over-diagnosis or over-investigation and the over-treatment which may stem from them, where that is inappropriate, either based on the patient presentation or the patient cohort, such as very older populations or very young populations in which the condition is rare or unexpected. The third item for policy promotion should be around adopting and implementing international standards for diagnostic criteria and when to treat based on diagnostic results. So how diagnostic results are interpreted and how they are acted upon by clinicians. So this is all at the diagnostics level, which is obviously only one part of diagnosis. The second area for which there are existing levers for improving diagnostic safety is around the health workforce and how people practice diagnostics across the healthcare sector. So encouraging a culture of diagnostic safety, involving teamwork along the diagnostic process and collaborating between different healthcare professionals to both come up with consensus around diagnosis, and also for exchanging information when a diagnosis is made, including communicating that diagnosis effectively to the patient and to other healthcare workers who may be involved in the patient care pathway to ensure that information is not lost or missed or that communication is not delayed. And that's particularly important where there is a chain of information flow in diagnostics, for example, in cancer screening, where a screening result has to be conveyed to diagnostic service providers, and then that in turn should be communicated to cancer registries and cancer treatment centres. The third area for levers for patient safety to reduce diagnostic error involves the infrastructure of the healthcare system, particularly with regard to information flows. So leveraging existing or developing new digital tools to monitor and report diagnostic performance, to also track results from diagnostics and diagnosis and communicate these as alerts to healthcare providers and also to patients. So we also surveyed in how many countries the diagnosis was available to patients via electronic healthcare records and shared with them as soon as they become available. And then also to integrate digital tools and AI in performing follow-up checks of diagnosis and reviewing existing diagnosis to check that diagnostic criteria are satisfied, that diagnoses haven't been missed, and that diagnoses are still relevant and pertinent and that they haven't expired where a patient no longer has a diagnosis. So a culture of diagnostic review, essentially. So those are all of the levers which we explore in our upcoming report on the economics of diagnostic safety. And that will be available for publication on the OECD website as of the 28th of March. And when you're kindly invited to consult that, I will place the link for the series on the economics of patient safety in the chat for further consultation. Thank you very much for listening, and the final slide will show up with their details. Thank you.
Thank you, David and Kate, for that was a tremendous amount of information in a very short time. So I have one quick question for you, David, that I wanted to go ahead and ask. Andre Robita asked about one of your graphs. Does the empty bar in the sepsis graph mean that there was no data or that the data was not reported?
The empty bar, that means that the indicator was not reported in that particular country, where they don't currently collect or report information on the indicator. There were 18 countries which replied to the survey. So surveys which are not included on the graph are the ones which didn't respond to the survey. So the horizontal axis includes all countries which responded to the survey, and absence on the graph means that they said essentially no, we don't report that indicator currently. I hope that's clear for everyone. Very good question.
Yeah, thank you. Okay, so next slide, please. So I'd like to introduce Sven Staender, who is Professor of Patient Safety and a well-known patient safety expert at the University of Zurich and former president of the European Patient Safety Foundation. So he is going to talk to us about patient safety reporting methodologies and potentials and barriers. So Sven?
Thank you for the kind introduction, Helen and Hussein, and for inviting me to this webinar together with Mirka. It is a great pleasure for me to speak to you today about medical error reporting. But before speaking about error reporting, we must spend some minutes on the topic of on error itself. Next slide, please. So in our daily lives, depending on the context, we often make dozens of mistakes every day. In this picture, this gentleman had obviously the wrong mental model, or he had a mental model, but he had made an error in interpretation of the context. So there are even studies that show that errors are a part of the natural learning process and that about 15% of tasks should be solved incorrectly in order to learn optimally. So error constitute a definition and constitute an effect on human life at all. Next slide, please. However, mistakes can have a high potential for damage. When it comes to medicine, we as patients expect no mistakes to be made because we don't want to be harmed even further by the treatment. Unfortunately, however, this is an illusion. Errors are also an everyday occurrence in medicine. This study from England, for example, examined the medication process and found that there are over 700,000 serious errors in the prescription process and over 350,000 in the dispensing of medication in England every year. Next slide, please. Or take electronic health record systems. In this simulation study of an electronic medication prescription, depending on the software used, 8 times as many errors occurred with the least favorable software. So it's difficult to blame the individual for these errors when they are forced to work with a software that is not optimal for their work. Next slide, please. But what exactly are errors? This question is not trivial. According to risk experts, a useful definition is actions that do not meet expectations. Ultimately, an action that is assessed as an error only becomes an error if the outcome does not deliver the desired result. The same action that leads to an expected result is that not an error. Take this picture. Is it an error by itself? Is the action itself already an error? If everything goes well, then it was at least risky. On the other hand, if it results in an accident, the action is considered to be an error, definitely. Next slide, please. However, failures are not only an individual matter. According to the famous Swiss cheese model by James Reason, there is often a whole series of precursor weaknesses in the development of failure. In this context, humans are almost always the last link in the chain of failures, and they are blamed. And that, by the way, leads to the often heard notion of human failure. But this notion does not take into account the various other precursors that also failed. It may be the technology, the process, or the organization before the error is happening. Next slide, please. On superficial examination, this often leads to humans being seen as the weak link. Basically, the bad apple in the system that has to be eliminated. It is then often heard that complex systems would be safe if there would not be this erratic behavior of unreliable people, or that system failures occur unexpectedly and only because of the human factor in the system, or classically, human error is the cause for accidents. Next slide. This view often does not match with reality, because behind the often simple first story, there is often a story behind. The first story may say somebody wasn't paying attention, or if someone had interpreted the data correctly, nothing would have happened, or someone should have tried harder. But the story behind is often a little bit more difficult. A complex system is not safe by itself. The people in these systems know the intrinsic risks and dangers and can deal with them. So at the end, people are not the risk, but a valuable resource. Safety is never the only goal. Think of the goal of costs, efficiency, and process times. And people try their best to take all the goals into account. And they develop strategies that are later seen to maybe have been wrong. Next slide, please. Synnøve has published a great deal on this topic, and his recommendation is, if you really want to understand errors, you have to understand why the decisions your team made at that point in time made sense to the team. And a very important question to ask is, could it have happened to someone else in your team? So the most important question to ask, therefore, is not who did it, but why did it happen? And what can we learn from it? Next slide. With this in mind, we set up an error reporting system at the University of Basel now 30 years ago. You can see me 30 years younger than today and with a little bit less weight. So time and again, We potentially mixed up two medications in anesthesia, for example, which were completely different, but whose labels looked very similar, as in this picture. There were lots of examples like this, which we had often reported in confidential discussions among each others, for example, at a coffee break or somewhere else in the hospital. Next slide. So these were the basic thoughts when we set up this incident reporting system now 30 years ago. The idea was that employees identify problems and incidents. They report these incidents. These incidents are being investigated. The resulting experiences are shared and improvements are systematically implemented in order to learn or improve the system. Next, please. The role models for the creation of our incident reporting system were the anaesthetists in Australia with the Australian Incident Monitoring Study around Bill Runciman, and aviation with the Aviation Safety Reporting System, ASRS, run by NASA. Next slide, please. In the meantime, this very useful tool has often become an excuse for risk management. Today, when you are asking hospitals to report about your experiences in risk management, you very often can hear statements like, "We have introduced risk incident reporting, that's enough for risk management," or "I don't have any resources for incident reporting," or "When I write a report, nothing is happening," or "Our risk officer will take care of that," or "It is always the same cases that are reported." And so people are more and more frustrated about risk management and the tool of incident reporting. Next. So after now 30 years, we understand what incident reporting should not be used for. It should not be used for the measurement of risk. It cannot be used to compare different hospitals or departments, and it cannot be used to track risk trends over time. Why that? Because we have a lot of unknown factors that either support or prevent people from reporting. And as incident reporting is voluntary, nobody knows the total number of events that's really happening. So simply speaking, counting incidents is a waste of time. Next. In order to make the most out of incident reporting, we can again look at our role models in aviation. They have a long tradition and have successfully implemented incident reporting. Sorry. The main conclusions from looking at aviation are they have a long tradition in safety investigation, and therefore they know how to deal with incidents. They look for everything, means that they encourage general reporting, but they also look for the specific when, for example, introducing new technology or procedures. Their approach is that incident reporting points at a problem, and that the detailed examination must be carried out separately. So incident reporting is not the examination of the problem at all. In aviation, the reports go to a risk department and not to the direct supervisor, and reporters are involved in the investigation process, so it is not just report and forget. So incident reporting in aviation is used as an early indicator that something must be looked at more in detail. Next slide, please. To successfully implement incident reporting, the following recommendations can be made. You must provide resources. Incident reporting cannot be done on top of your already busy day, and analysis as well as implementation of learnings need resources as well. Incident reporting shall not be the sole tool in risk management. A system for in-depth analysis must be implemented, like the London Protocol or a tool for root cause analysis. You should involve reporters in the analysis, and people shall not report to the direct supervisor. You should focus on high-quality reports, and you must not misuse incident reports to measure risk. Last but not least, you must provide the insights of the reports to the users. That generates learning from the cases, as well as knowledge about systems improvements. Next slide, please. So in conclusion, it can be said that incident reporting basically is a tool for learning. But if we only learn from our mistakes, as in this example with a theoretical failure rate of 1 in 10,000 cases, then we miss more than 9,000 good actions from which we also can learn. Next slide. Put it simply, this is the difference between safety 1 and safety 2, where safety 1 was only focusing on the error, And safety 2 is looking also for success actions in our daily work. Next. So do not only report failures, but also success. Because remember, please, next slide, please. We teach our babies how to walk and not only how to avoid falling. So I think we must much more look at success and not only at the failure rate in our hospitals and our healthcare systems. Thank you very much.
Thank you very much, Sven. Another really informative presentation, and we have many questions piling up in the Q&A in the chat. So we will now start our panel. Thank you. Again, the speakers will be joined by Synnøve Serigstad from the Norwegian, let me get this exactly right, Healthcare Investigation Board, which is a very interesting institute. Anupoma Haque from Austria, who is a public health expert and patient safety advocate, and Jolanta Bilińska from the World Patients Alliance and the City Medical Center in Lodz, Poland. So these are their bios. Next slide, please. Next slide. And next slide. And I think we can take down the slides now and put the group up so that everyone can be seen. I would like to start the questions by asking our panelists something about what they do so that people can understand where they are coming from. Synnøve, are you back yet? I know she had
I'm back. We had a fire alarm, and it was not a false alarm. It was actually a microwave in this office building, but I'm back. All good.
Oh my goodness. Okay. Well, I wanted you to explain a little bit about medical error in Norway and what the Norwegian Healthcare Safety, Norwegian Healthcare Investigation Board, does, because it's a very interesting organization and it's a model for other countries. There are very few of these in the world.
Yeah, thank you. So I come from a national independent organization in Norway, and our mandate is to investigate serious adverse events in the Norwegian healthcare system. So we're kind of a national whistleblower. We are independent. That means that we are independent from the actors that we investigate. One thing is the hospitals and the municipalities, but we look at explanations in the system level and in the frame conditions for the healthcare to deliver good and safe services. So we can also investigate the Department of Health, the Health Directorate, the supervision authorities, and so on. So that's important. We are also a non-sanctioning, strictly source protecting. That means that we have no sanctions. Our investigations are conducted solely for learning, and we don't tell anyone who we are talking to, and we don't tell where we go, where we do our investigations. If we do an investigation in a neonatal unit, we don't name where we went into. We go into cases that could have happened everywhere, and we use these cases like a door opener to a wider team. So that's who we are and how we work, and we investigate the most serious adverse events and serious conditions that may threaten the patient safety.
That's very interesting. What are the main barriers that you find in this work?
Well, the main barriers we find, of course, the same as have been mentioned here earlier. But from our point of view, I would say that perhaps one important barrier is the fact that you can be the sanctions that health personnel may experience when they are a part of a serious adverse event. That's a barrier for reporting this event, and for have the courage to kind of go into it and talk openly about it. And that's, from our point of view, it's easier for us to go into these events because we don't have these sanctioning powers. We don't do that stuff, but we find that is a main barrier. That is a barrier, absolutely.
Well, thank you. Well, Anupoma, I would like to ask you about what you do and how your public health work intersects with the concept of medical error reporting and medical harm, for that matter.
Thank you, Helen. I'm very happy to be here and share my experience with you. So basically, I am a health care professional, but I also provide care for my family member with rare disease. And I'm also a medical researcher. So altogether, I bring all these hats when I am advocating for patients. And in my current, one of the projects, which is a cost action called Better Care, there we are actually focusing our attention to the informal part of care. We have been talking in this presentation also mostly care that is happening in a formal setting. So we can say a clinical setting. So maybe a clinic, maybe hospice, mostly hospitals. And there, comparatively, when medical error happens, maybe there is a system installed already which you can use to report. And maybe there are infrastructure installed already to start a process. But you can also imagine that care doesn't only happen in hospitals. In fact, majority of care can also happen at homes. And for our elderly population, which is growing every year and which will be around 1.4 billion by 2030, care mostly happens at home, usually by a family member, for men, by wives or children or neighbors, or maybe an invited friend. And error happens there too. So Better Care is focusing on the medical errors that happens in informal care at home and how to make it safer and better. In addition to this, previously, with my 23 years in public health, I have had the opportunity to study healthcare systems in different capacities. And I have my lived experience as a patient myself and also with my children with rare diseases. So I have seen medical error occurring from all these perspectives, as a patient, as a parent, and also as a healthcare professional. So you can say I wear many hats in this work.
Well, thank you. Thank you very much, Anupoma. And now, Jolanta, tell us your perspective on patient reporting. I know that's something that you're very interested in. How can patients report medical harm?
Thank you, Helen. Hello to everyone. 20 years ago, I just started my interest in patient safety from medical error. It happens I used to be a journalist, and one doctor called me on my duty and the newspaper, and he reported 17 newborn died and 78 were infected because of the dirt in the hospital. I want to be short, so we did investigation with help of one professor from National Public Health Institute. And what happens? The chief sanitary inspector checked all neonatology department in my country and happens that everywhere were errors, mistakes. So they decided from that time that in every hospital and every must be a special reporting system if any intra-hospital infections happens, and also a team of epidemiologists which take care of everything what happens in the hospital. Why I am telling it? Because we had that time many discussion in media how to communicate about errors. Is it good that media report that nurse, for example, pumped 1 liter of nutrition liquid to the instead of analgesic to the spine of a boy and he died, or that one woman who broke a leg came to hospital and the doctor who was on duty was a dentist. He made a wrong operation and after 2 days the patient whole leg had to be removed. So people were very frustrated. They didn't know whom to trust, because it happens that some people went to the hospital for surgery and the woman had, for example, very big pain, and what happens, she had the bandage left in after the surgery. So this example we can multiply. So in Poland, after this big discussion, they decided to do a special commission that for every 50 euro, a patient had a possibility to check with 2 doctors and 2 lawyers if the medical errors happen in the hospital or not. It was a very successful idea. It's a pity last year they closed this possibility, but I am sure spokesman will come back to this idea, because we need to teach people what is a medical error, how to report, how prevent, how to be more empowered in the own path in the hospital. You know, it happens sometimes the medical error happens because of the wrong communication, as it was in the presentation, due to this wrong dispensation of medicine, or sometimes even bad condition of medical equipment could make a very big error. Also in my country, a few years ago, women during the chemotherapy burned the body because of the very old machine. So I think what is important for us, for a patient advocate, is to teach people to be aware of the treatment process, and that we are involved in the treatment. I think it makes us more conscious and more responsible and avoid the medical errors also. Thank you.
Thank you, Jolanta. Okay, so now we are right at time for our 1-hour webinar. If you are able to stay on, as I said, our speakers have graciously agreed to do so for another 15-30 minutes. So we will go to the questions from the audience now, and you know, you may leave if you want to, and that won't hurt our feelings, but you're also welcome to stay. So the first question I see is, I mean, we have so many good questions, and even with extra time, we won't get to all of them. The first one I see is a question about, for David, about overdiagnosis and underdiagnosis. So what is the opportunity cost, you know, in comparing the two? That's from, I think that's from Helen Hernandez. I can't quite see my questions
Okay.
at the moment.
Thanks for sharing that question, Helen. It's to do with the opportunity costs of overdiagnosis relative to underdiagnosis. Is that right?
That's
Okay,
correct.
so in our report, we defined overdiagnosis as a diagnosis made for a condition which would not have affected the patient's health outcomes during their lifetime had it not been diagnosed, and that can result in overtreatment with harms to the patient and additional costs. Whereas we defined underdiagnosis as a systematic error that occurs routinely, whereby certain patients or certain types of patients, their diagnosis is routinely missed, and therefore we grossly underestimate the incidence or how common that condition is in them. Examples can be, say, the presentation of heart attacks in women sometimes, or chest pain in women, or, for example, underdiagnosis of ADHD in adults. In our economic analysis, we estimated the costs for overdiagnosis to be greater than that for underdiagnosis. Approximately 3% of healthcare expenditure was wasted on overdiagnosis, compared to about 1% of expenditure on underdiagnosis. So overall, overdiagnosis represents a greater problem compared to underdiagnosis, but those are conservative estimates, as they're both difficult to measure, particularly underdiagnosis, and it also depends on the condition being diagnosed. So I hope that answers the question.
Yes, thank you. And I would think also you get a lot of perhaps overdiagnosis of one condition that is underdiagnosis of another.
Yes, like almost like a misdiagnosis. One condition is confused with another. We gave the example, for example, of viral infections versus bacterial infections. So you can say that a virus may be misdiagnosed as a bacteria. The patient is overtreated with antibiotics. That causes the patient harm and also can induce resistance to antimicrobials. And there's the additional cost to the healthcare system and insurers of covering that. We explored it through the lens of misdiagnosis, overdiagnosis, and underdiagnosis as the best way of estimating both harm and cost to patients and providers.
Thank you. And I'm sorry, I made a mistake. That question was from Juanita Nalanjogi. I hope I'm pronouncing that right, not from Helen Hernandez. But I will now give you a question from Helen Hernandez. She's asking about data on rare diseases. What is available? I believe this again is for the OECD speakers.
In our upcoming report, we didn't specifically focus on rare diseases such as metabolic conditions or genetic conditions in our report. We really made the focus on cancer, sepsis, and mental health disorders, which represent the greatest burden of rates of diagnostic error. So we don't have any new information to provide on rare diseases, but obviously they are more difficult to diagnose. Often there are no specific tests available, or where they are, it relies on first clinically picking up the presentation and then administering a correct diagnostic test later. So I think diagnostic delay is likely to be the major component for rare diseases there, rather than, say, a misdiagnosis, overdiagnosis. That's helpful.
Yeah. And I think the cumulatively rare diseases are not so rare. They, as she points out.
They say each individual one is rare, but rare diseases of the body are actually affected. I can't remember what the statistic is, but I think it's available on the Orphanet website, which is the reference for the EU.
Okay, yeah. So then another question that has come up several times, this is from Ofra Balaba in Israel, but several other people asked the same question about other systems, and I think this is probably mainly for Sven, other systems for measuring errors. So specifically AI and data mining of medical records, that sort of thing, patient reporting. What other systems are available or in existence now and or being developed or have potential to be developed? I believe you're on mute, Dr. Staender.
Sorry. I think you already mentioned the available tools, but I would like to say it is not a question that we must have additional tools. If only we would use the tools that we already have appropriately, then the system could improve tremendously. I like to always compare a little bit with aviation. When you think about what the aviation industry is spending on resources and money into safety investigations and improvement, and compare it to what the healthcare system is spending into improvement, into safety questions, I think there's a huge difference. So I think we do not need more tools, but we do need a shift in the priorities in our healthcare systems, a priority to safety, and safety not as a byproduct, but safety as the main product of our daily work.
Yeah, that's a great answer. And Kate, do you have anything to add to that? Is Kate still with us? Or David? Yeah.
Yes, I'm still here. Yeah, well, I think Sven's comment about the appropriate investment in the tools that we already have is a really important one. Of course, coming from the OECD perspective, I think that we really advocate for patient reports because that's an excellent resource and often provides very different perspectives on how frequently errors are occurring, and what kinds of errors, and the errors that are really affecting people. Of course, would also recommend further work and development of staff surveys to get perspectives on some of these cultural issues that can influence reporting, and also reflect the culture in regards to if someone will be punished, or if there's a learning system in place in their organization. And then finally, there's, of course, I think opportunities to leverage digital technologies, to use things like trigger tools that would identify events in electronic medical records, or AI. But of course, this is something that we explored initially in the diagnostic safety report, which is that it comes with opportunities, but also with the risks, and that we don't see really a system yet that has been able to kind of scale up the use of these technologies in health systems.
David, did you have anything to add to that?
No, nothing major, just some additional indicators on, using digital tools and availability of linking medical records for patients and other healthcare providers, allows sharing of diagnostic information and diagnosis made in other healthcare settings to improve the communication and avoiding loss of follow-up of information that might be important. So using existing tools to better effect rather than relying necessarily on new technologies.
May I add something here, Helen, if you allow me?
Yes, absolutely.
Yes, we do have a lot of tools already, and it can be better utilized, but we should also remember that any tool can improve. So we should always strive to improve the tools that we already have. For example, Sven talked about softwares. Softwares can, in my experience, I have seen a lot of softwares that have been developed in-house by hospitals or health organizations. But if you compare to the market quality, they are not really very good softwares. And I don't know why there is this craze of, developing softwares in-house. And they always talk about data protection and privacy and these kind of issues. But at what cost? It should not be at the cost of quality and increasing the risk of patients. That's one. And secondly, we can at least do one thing that will not cost us any money, is changing the attitude from patients know nothing about risk, safety, and errors to patient is my partner in noticing these errors. I can share my personal experience. I was in the hospital staying with my child. So I wasn't the doctor, but I was the patient's mother. And when I noticed some errors and reported to the doctor, I was deemed as, the difficult patient, or the Dr. Google, or the troublemaker. So as a doctor, I think we can improve a lot of things. If we see the patients as our partners in noticing and reporting errors, and that will not cost us any money. Thank you.
Yes, that's an excellent point.
Great topic, Helen. May I add on this a little bit, because
yes, please.
Anupoma made a very important point when it comes to software that we are using in our hospitals. Are you aware that all the software that is even not only developed in the hospital itself, but even from big companies sold internationally, that no usability testing is necessary for the software, for example, that is used for electronic health records. No need for usability testing. Imagine this in a cockpit. If there would be no usability testing for a new instrument in the cockpit, it's unbelievable. But there's no regulation that says that there must be a usability testing before a new software is introduced into the hospital. That's one aspect where I'm shaking my head.
Yeah. I think there are many examples like that in healthcare as well. Yes. Synnøve.
Yes, thank you. I just wanted to add the point from Anupoma with patients and next of kin reporting, which is of course really important on a local level, but it is also important that patients and next of kin are given the opportunity to report into the national reporting system, I think. Well, because in Norway we have, local reporting system at each hospital, but also we have a national reporting system, and the insights and the opportunities from patients and next of kin to report into that system is really, really important, we think. And it adds, well, you can't actually see the whole picture if you don't get that kind of information. So, but just to build up on your argument, Anupoma, it's really important on all levels.
It is. I mean, if I can even add as moderator, which I should not, but I think it's critical you get a very different picture from patients, and often what is in the record leaves out some of the most important parts. So yes, I think that's critical. So next question that I have is, I think again, this one is for Sven. How do you collect examples of positive incidents? Do we have a system for doing that?
Well, I think, again, we don't need another system. We could introduce it into our existing incident reporting systems. You simply must change a little bit the focus and ask people to report about success that they have in their daily routine. For example, in my department, I changed a couple of years ago the daily report that we have in the evening after we finished our surgeries in the operating room. Because usually I was asking, was there anything wrong today? Had you any problems? What went wrong? And then I switched and I asked, what went exceptionally well today? Everybody looked at me and said, why are you asking about this? Because, but it offers a huge discussion about improvement, and it offers a culture of talking about things that are not perhaps guideline approved. Perhaps they are a little bit out of the guidelines, but they proved to be working well at the end. So I think it's not easy to switch between safety 1 thinking and safety 2 thinking. But safety 2 thinking is putting the human potential much more into this scene. And that's, from my point of view, an important aspect, because we must be aware people are coming to work in healthcare and everywhere, and they do not want to do harm. There's a system that forces them that way. Complex systems, most of the time, forces them to do things that they do not intend to do. And we must learn from the errors, but also people have the ability to do things that are a positive event at the end of the day. And we must also learn from these positive events.
Great, thank you. So I have a question from Sabah Zahuruddin, asking, what is your take on accreditation? She says, accreditations provide many useful process designs that help clinical staff comply and remove the risk of error. Are they underused? Are they expensive to implement? I think the question is, why are they not used more? And I assume this is recommendations from accreditors that you're talking about, Sabah. So again, I think, Sven, that may be a question for you.
Yeah, I think the role of the accreditation is definitely an important role. But again, if we do not have a culture of safety, if we do not have a culture of improvement, then accreditation is only one aspect of the whole picture. It can force the hospitals to do something, but I'm not sure that it will be the magic bullet that will drive performance into the right direction. I'm very much impressed by the data from OECD about the cost of safety. And when you imagine, I think, correct me, Katherine, if I'm wrong, there are, I think, already 2 reports that say that at least more than 10 or 11% of direct costs in the hospital belong to poor quality and safety aspects. So this is not only a huge burden on the individual fate of the patients involved, but it's also a huge economic burden. And we must ask ourselves, how can we turn the ship around, and what must we do to invest more money into safety? Yes, accreditation definitely is a point, but I think we must also put up pressure on the political decisions in our countries to spend more money into safety. Simply.
Yes, anybody else have comments on that? Kate, Kate and David, we have a question about your methodology. How do you assess the quality of data that you get at OECD? And then, yeah, how do you collect your data? Where does it come from?
Yes, I can take this. Well, first, just to reflect on what Sven said about the economics of patient safety estimates, I couldn't have said it better myself, but it was a very good encapsulation of the messaging. But there are quite significant costs to the health systems that could be better directed and should be invested in the first place in improving systems so that these errors don't happen. Regarding the OECD data, we get this from official sources. So we work with national governments to standardize the collection of indicators. We use standardized guidelines on how indicators should be collected, and then we receive the data from the ministries of health or ministries of social affairs, whatever ministry is the data custodian for the particular indicator. And then internally, we have a number of validation processes where we validate internally, but then also with the delegates, the representatives from our member countries to ensure that the data is representative, that it meets the criterion, that the data is comparable across countries, because that's a significant concern, especially when we're collecting data from so many different data sources. So I think that's a short answer, that we're receiving it from country governments as official estimates from the countries.
And are some of your reports or surveys of various experts around the world, some of the patient safety reports? Am I wrong on that?
Yeah, so it depends. The methodology depends on the particular research question that we're asking. So, for example, for the first economics of patient safety report, we conducted a survey with experts, patient safety experts. We also, for particular outputs. We'll send snapshot surveys to our delegates to better understand the situation within a certain country. It's not necessarily part of our core routine data collection, which for most of the patient safety indicators occurs on a 2-year basis, but a one-off data collection around a particular topic for us to better understand the international landscape.
So then we have another question that's sort of along those lines. What are the main gaps in the current literature that involve cost effectiveness of patient safety practices? So is there a good assessment of this in the literature?
Yeah, so I think maybe I can start, and then other panelists can also add in. It would be great to hear some other perspectives. But I think from the literature, of course, from the OECD side, we've been spending a lot of time evaluating the costs. So as kind of looking at it 2 ways, the carrot and the stick. We've been looking at mostly the stick, what it costs systems if it's going wrong. But I think just as the whole safety field is moving from safety 1 to safety 2, I think where there's a particular gap and where much more work could also be focused is to look at the potential gains from investments in the most effective systems and improved learning systems. So here we have some estimates from the OECD, but I think that quite a lot more could be done to look at the cost benefit of investments in some of these interventions that we've been discussing, which would be even further motivation for policymakers to place resources where needed.
Helen, you're muted.
Sorry. Does anyone want to add to that? Anyone want to come down hard?
Yes, I would like to. If you ask about what is available or what are the gaps in literature, because I'm working now on safer and better care provided and errors prevented in the informal care setting, I can assure you that there is almost no literature about errors happening in the informal care setting. We are actually writing them, so there are a few. But also, if we look at the formal care setting and errors happening there, as Katherine stated, they are at the mercy of national bodies who are collecting data in their country. So it depends on what they are collecting and how much they are collecting and from where. But in my opinion, there is not that much lack of data, rather use of data, sharing of data. In Austria, we collect a lot of data, not just at hospitals, but also the health insurance companies and other bodies. The problem is these different bodies, different authorities, or the owner of the data, they don't share their data with each other. We could have a lot of data and a lot of triage if only this data was shared and utilized. So that is a very big gap there. And of course, if we focus on also what went very well, that kind of reporting is not there, I think, which Sven was talking about.
And I think also sharing with the public is something that most healthcare establishments are very reluctant to do, but it is, yeah, I think absolutely necessary to have transparency, both input and output for the public. So I have a question, one more question, I think, and then I will turn it over to Mirka to close us out. But I have a couple of questions about protections for patient safety incident reporters. What sort of protections exist in various countries, and what sort of protections should exist? Sven, do you have thoughts on that?
Well, I think we already heard about. I think Kate stated this that we must be very careful not to blame people for reporting incidents or even accidents. I think this is the most critical point. As soon as you start blaming people for reporting, then the culture of safety improvement is dead from 1 minute to the other. So I think this is a most important part. I'm not sure whether there is a regulation, at least, for example, in my country, in Switzerland, we do have the obligation in Switzerland that hospitals must run incident reporting systems. But I honestly must say I don't think that we have rules how to deal with so-called unruly behavior of hospitals when it comes to blaming people, for example, when they report. I'm not sure. I think this is on the local level. At least that's what I know from my hospital and the other hospitals I've been working at, that the culture of work has been defined by the directors of the hospital, but I'm not sure if there are regulations on a national level. But I'd like to learn more about this. I don't know.
Synnøve, do you have any insights on that from Norway?
Well, I agree what Sven says. Actually, it's more of a cultural problem, I would say, because also in Norway, all health institutions that deliver healthcare are obliged to notify, and there is not a legal. Well, you have the bad apples, which are really rare, and they are taken care of in a legal path, so to speak, of course. But then it is up. The important thing is that the psychological safety on the workplace, and the cultural how the safety culture is actually, and how you look upon these is this accident or error an opportunity to learn, and is it safe to take that opportunity on our workplace? So I think it's more of a cultural question than a legal question, and it's something that has to be worked on all the time.
Yes.
In my country, can I say? In my country, in Poland, we have the reporting system, reporting errors and adverse events, if the hospital will receive the accreditation. So we have among 800 hospitals in the country, and only more than 200 have accreditation. So in these accredited hospitals, there exists this reporting system of errors and also adverse events. As mentioned, Sven and others, this is a psychological issue, because every of us has a trait not to report errors, even in private life, even in professional life. So we really need to teach the nurses, teach the doctors to be more open in this reporting, in finding the solution, what to do, because many times we cover this adverse events, these medical errors, and we not show even to the patient or patient family. There is very often a patient received a wrong doses of medicine or is falling down from bed in the night, and we never will confess, oh yes, it happens in the hospital. We just don't see this issue. So I think it is a lesson for us as stakeholders, and also a lesson for the patient. We need to be more open in reporting and in finding the solution. And somebody told in the presentation, we should have international standards for reporting, for finding the proper solution. Thank you.
Thank you, Jolanta. And now, Mirka, please take us home.
Thank you very much.
Is there a minute to add to that last question? Because I think it's very important. Often people, patients, of course, or even healthcare professionals are afraid to report error because of this. We have a tendency and popular culture of reactiveness rather than proactiveness. Here also, I would say that we need to change our attitude to how we evaluate harm and non-harm. So whenever something goes wrong, some harm happens, we react and we jump to find who we can blame or what we can blame and then punish. But history has taught us that blame and punishment actually does not prevent harm from happening. So maybe
That's a very good point.
if we change our attitude to when something happens, well, what could have been done so that this does not happen again? If that is our attitude, then maybe people would come forward to reporting this kind of errors and incidents, no matter what the cause was. Maybe it was a severe harm. That's where we are more proactive. But if we are not afraid of reporting, then smaller incidents could also be reported. And also, last point, let's reward and celebrate when nothing happens. When no harm is done, no error happens, we kind of tend to take healthcare professionals and clinical settings and say, oh, it's our job, nothing happened. Of course, that's what we're supposed to do. But a lot of people did everything right. A lot of technology functioned properly, so no harm was done. So maybe we should also reward.
Okay, thank you, Anupoma. I think that's
Thank
great.
you.
We need to let Mirka wrap us up because I think people are dropping off, but I really appreciate your input. So Mirka.
Yeah, just just for a small interruption. I just wanted to, update everybody. Our next webinar is going to be on patient advocacy, is from Asia Pacific region. So you can register now. My apologies, Mika, over to you now.
No problem. No problem at all. I'm really happy about this discussion, and I would like to, on behalf of European Patient Safety Foundation and World Patient Alliance, I would like to thank to our speakers, Helen for excellent moderation, and all participants for joining us today. I think it's been clear from this webinar that this is very much needed discussion. And from our side, we will definitely do our best to continue talking and bringing these points on the agenda. I think another point that has been really clear from today's discussion that we need all actors at the table. Everyone has need to understand the other point of view, because that's very, very important so that we start changing this culture. We start taking patients as partners. We start understanding and seeing the role of patient organization and patient advocates as very important source of information that can help improving system, especially during these times when the healthcare, especially in Europe, but also in other countries, is going through the crisis, and we need to help each other to make it safer for everyone. We need also independent investigation bodies that will bring no blaming culture and will help us to learn from the errors. And we need all the other actors, and especially decision makers, the policy makers, to understand that investing in patient safety and in quality of care will make a significant cost, will bring us the resilience that we need, and will help everyone regain trust, maybe also in the healthcare system, because many countries are now facing these problems of trust. So I would like to encourage everyone to continue discussions, continue thinking about these topics, and please follow both World Patient Alliance and European Patient Safety Foundation on our activities, and join us for future webinars, for future events. We will be really happy to have you together with us. So thank you again for today's webinar, and hope to see you soon.
Thank you, everyone, for joining us. And the recording and the slides will be on the webpage. Thank you again.
Thank you. Bye-bye.
Thank you. Thank you, Helen. Thank you, everyone.
Thank you. Thank you
Thank
so
you.
much.
Thank you.
Thank
Bye.
you so much. Thank you. Bye-bye. Bye.